The general session number 4, I'm Terry Mamones. I work at Orlando Health Cancer Institute in Orlando, Florida, and I'm co-moderating this session with David Giles of UT Health San Antonio. So we have several presentations this morning, and with no further ado, we'll start with the first presentation that will be given by Andrea Barrio from Memorial Sloan Kettering. This is a virtual presentation, and she will discuss impact of race and ethnicity on incidence and severity of breast cancer-related lymphedema after axillary lymph node dissection, results of a prospective screening study. Dr. Barrio.
Okay, let's see what happens.
Severity of breast cancer-related lymphedema after axillary lymph node dissection, results of a prospective screening study. I have no disclosures. Breast cancer-related lymphedema is a frequent and feared complication following axillary surgery for breast cancer. It is a chronic, disabling, progressive condition which negatively impacts quality of life and typically occurs within the first 2 years after axillary surgery, with a recent study demonstrating the peak incidence after axillary dissection and nodal RT occurring 18 to 24 months post-surgery. Axillary lymph node dissection remains the main risk factor for the development of lymphedema. Other reported risk factors, such as older age, increasing BMI, systemic chemotherapy, including taxane-containing regimens, and radiation therapy, are inconsistent across studies. Epidemiologic studies have reported an increased susceptibility to lymphedema in Black women. However, prospective clinical data is lacking, and lymphedema risk in other racial minorities has not been well studied. As treatment paradigms change, it is also important to understand the impact of modern therapies such as neoadjuvant chemotherapy on lymphedema risk, which remains uncertain. The aim of our study was to assess the incidence of lymphedema in a prospective cohort of patients treated with axillary dissection using defined measurement protocols, to identify risk factors associated with lymphedema development, and to evaluate the impact of race and ethnicity on lymphedema incidence and severity. We enrolled patients into our prospective lymphedema screening study from November 2016 to March 2020. Eligible patients included female breast cancer patients aged 18 years and older undergoing unilateral axillary dissection either in the primary setting or after sentinel lymph node biopsy. We excluded patients with a prior history of unilateral or contralateral axillary surgery, as these factors could interfere with the accuracy of the volumetric measurements. All patients gave written informed consent to participate. Volumetric arm measurements were taken with the perometer, which uses a sliding frame and an infrared light sensor to measure limb volume with a high degree of accuracy. Bilateral arm measurements were performed at baseline, postoperatively, and every 6 months for a total of 2 years. Lymphedema was defined as a relative increase in arm volume of greater than 10% from baseline, using the relative volume change formula listed here, where A1 and A2 were the volumes of the affected extremity at baseline and follow-up, and U1 and U2 are the volumes of the unaffected extremity at those same time points. This equation accounts for the natural asymmetry between the arms at baseline and uses the contralateral arm as a control to account for changes in arm size other than lymphedema. Patient variables such as BMI and volumetric arm measurements were prospectively collected. Race and ethnicity were self-reported by the patient, and clinical and treatment variables were retrospectively collected. Clinical pathologic characteristics were compared between racial and ethnic groups. Kaplan-Meier cumulative incidence plots were constructed to estimate the incidence of lymphedema. Uni and multivariable logistic regression were used to identify factors predictive of lymphedema, and lymphedema severity was compared across racial and ethnic groups by evaluating the maximum relative volume change across all time points. From November 2016 to March 2020, we enrolled 827 patients onto our lymphedema screening study. 411 patients had a sentinel node biopsy alone and were ineligible to remain on study. An additional 112 patients were ineligible for a variety of reasons, including study withdrawal, failure to obtain a baseline measurement, or prior axillary surgery. 304 patients had an axillary dissection and remained on study, and 276 had at least one longitudinal measurement after baseline and comprise our study cohort. Median patient age was 48 years. Median baseline BMI was 26.4. 60% of patients were white, 20% were Black, 11% Asian, and 6% Hispanic. The majority of patients presented with clinical T2 or T3 disease, and the majority were clinically node positive and had ductal histology. 68% of patients had hormone receptor positive HER2 negative breast cancer. 70% of patients received neoadjuvant chemotherapy, and the remainder had upfront surgery, with the majority receiving adjuvant chemotherapy. Of those patients receiving systemic chemotherapy, 94% received a taxane-containing regimen. 75% of patients had a mastectomy, and the majority had reconstruction. 95% received radiation therapy, and 93% received nodal RT. The median number of lymph nodes removed was 18, and the median number of positive lymph nodes was 2. This table shows the clinical characteristics stratified by race and ethnicity and highlights the characteristics that differ across the groups. White and Black women were older. Black and Hispanic women had a higher baseline BMI. Black women were more likely to present with CN1 disease, and Hispanic women with CN2 or CN3 disease. Black and Hispanic women were more likely to undergo breast-conserving surgery. Hispanic women had a higher number of lymph nodes removed, and Black and Hispanic women were more likely to receive nodal RT, likely reflective of their higher clinical nodal stage at presentation. The additional factors listed here did not differ by race and ethnicity, in particular, receptor subtype, receipt of neoadjuvant chemotherapy, number of positive nodes, and receipt of any radiotherapy. At a median follow-up of 22.6 months, 56 women developed lymphedema, and the 24-month lymphedema rate was 25%. The incidence of lymphedema varied significantly by race and ethnicity, with the highest incidence of lymphedema in Black women, with a 24-month lymphedema rate of 39%, compared to 28% in Hispanic women, 23% in Asian women, and 21% in white women. The incidence of lymphedema also varied significantly by treatment group, with a 24-month lymphedema rate of 31% in women receiving neoadjuvant chemotherapy, compared to 11% in those undergoing upfront surgery. On univariate analysis, increasing age, increasing BMI, Black race, increasing number of lymph nodes removed, and increasing number of positive lymph nodes were associated with lymphedema development. Receipt of NAC and increasing time from surgery were also associated with lymphedema development, while mastectomy and patients with HER2-positive breast cancers were less likely to develop lymphedema. The factors listed here, in particular, change in BMI, clinical T and N stage, histology, and nodal RT, were not associated with lymphedema development. On multivariable analysis, Black race was the strongest predictor of lymphedema development, with a 3.5-fold increased incidence of lymphedema compared to white women. Hispanic women had a 3-fold increased incidence of lymphedema development compared to white women, although notably the number of Hispanic women in the study was small. Receipt of neoadjuvant chemotherapy was associated with a 2-fold increased incidence of lymphedema compared to upfront surgery, and increasing age and increasing time from surgery were associated with a modest increased risk of lymphedema development. BMI, receptor subtype, number of lymph nodes removed, number of positive lymph nodes, and type of breast surgery were no longer significant on multivariable analysis. Among patients with lymphedema, there was no difference in lymphedema severity across racial and ethnic groups, with similar relative volume changes observed. The strengths of our study include its prospective design, large number of patients treated with axillary lymph node dissection, strict measurement protocols, and the diversity of the study population. We are limited by our short median follow-up, although notably most cases of lymphedema occur within the first 2 years, and we were unable to assess the independent effect of nodal RT on lymphedema risk as most patients received RT. In conclusion, we observed a higher incidence of lymphedema in Black women treated with axillary dissection and RT after adjustment for other variables. Similar findings were observed in Hispanic women, but confirmation in a larger data set is needed. Neoadjuvant chemotherapy significantly increases lymphedema compared to adjuvant therapy in women undergoing axillary dissection and radiotherapy. The mechanism by which neoadjuvant chemotherapy increases lymphedema incidence is unknown, but we postulate that neoadjuvant chemotherapy may cause fibrosis of tumor-filled lymphatics as well as lymphatic endothelial damage prior to surgery, resulting in higher lymphedema rates after axillary dissection. While neoadjuvant chemotherapy is often given to downstage the axilla and avoid axillary dissection, in patient subsets unlikely to achieve nodal PCR, alternatives to neoadjuvant chemotherapy to avoid ALND are needed. The etiology for the higher observed incidence of lymphedema in Black women is largely unknown, but may be due to race-based differences in inflammatory reactions, tissue fibrosis, or lymphatic function, and future studies should address the biologic mechanisms behind racial disparities in lymphedema development. I'd like to acknowledge my funding sources, including the Chanel Endowment for Survivorship Research and the Manhasset Women's Coalition Against Breast Cancer, as well as my surgical colleagues who enrolled patients on trial, and the research team who performed thousands of volumetric measurements on patients, and of course, all of the patients who participated in the trial. Thank you.
Thank you, Dr. Barrio, for your presentation. It's very nice and interesting data. This presentation is now open to questions. We'll have one from the podium, from the audience. Go ahead. Microphone, please.
Hello?
Yes. Okay.
Mohammed El Nagi, New York. Very interesting study, but I wonder, maybe the neoadjuvant chemotherapy effect is not because of the chemotherapy itself. It is likely because these patients mostly have enlarged lymph nodes, alteration of the lymphatics, and then that's what happens after the treatment. It is not because they got the chemotherapy. It is because of the involvement of the lymph nodes and enlargement of lymph nodes beforehand.
We included clinical nodal status in the analysis to see if that was an important factor in lymphedema development, and we adjusted for that. And the clinical nodal stage was not a risk factor on multivariable analysis. So we did take that into account because you're right that you would suspect that patients with more advanced lymph node disease might be more at risk for developing lymphedema. But since we included that in the analysis and adjusted for it, we think the association with neoadjuvant chemotherapy is real and has been also demonstrated in some other prospective studies, including ACOSOG Z1071.
Thank you. There are some questions online. One deals with, did you correct for postoperative physical activity with the idea that if you start with a higher BMI, there may be less physical activity postoperatively? So did you correct for postoperative physical activity?
So we did not correct for that because I think it's difficult to ascertain that data. We did not ask patients about their physical activity. We did monitor change in BMI over time. So at every time point that the patient came in to get a measurement, she got a BMI performed. And change in BMI was not associated with lymphedema development. Initially on univariate analysis, it was only baseline BMI.
It's interesting. Question by Dr. Yi. Were all patients referred to post-surgery physical therapy, and were any differences in usage?
That's a great question. There were differences in therapy usage. Patients are not automatically sent to physical therapy at our institution. When patients came to see us as part of the measurement protocol, if patients requested to be seen by lymphedema therapy or physical therapy, we made that referral. So there were a number of patients who did not develop lymphedema who were still symptomatic, who requested referral, and we sent them for treatment.
Another question online is, did you account for competing risks of recurrence? Could lymphedema be documented after recurrence? Did you?
We did account for that. And so if patients developed, we accounted for contralateral axillary surgery. So if patients developed contralateral disease, we censored them. No patients developed ipsilateral recurrence that allowed them to be censored. But if they developed ipsilateral or had additional ipsilateral surgery, they were censored at that time.
Another question asks, mastectomy patients had less lymphedema, as you showed. Was there less XRT in mastectomy patients?
So that was only on univariable analysis that mastectomy patients had a lower risk that did not hold out on multivariable analysis. The use of RT was high across the board, particularly in neoadjuvant chemotherapy patients, and 93% of patients received RT plus nodal RT in our study.
Very good. Another question, and I also have a kind of similar question to that. Any thoughts about preventive measures for lymphedema? And I want to ask also, did anybody in the study underwent either the arm procedure or lymph procedures or lymph node transfers, or any of that?
So we're currently at Memorial doing a study looking at prophylactic immediate lymphatic reconstruction with lymphovenous bypass. This recently just started in a randomized trial to see if this would reduce lymphedema rates. This started about a year ago, so we don't have results yet. None of the patients in our trial, because our trial closed before that study opened, got a prophylactic lymphovenous bypass. There were some patients in the trial, just a small number, about 7 or 8, who got a therapeutic lymphovenous bypass during the study. I did not separate out that data, but we did keep them included in the study.
Thank you very much. I think several other questions, but unfortunately we have to move on. Thank you, Dr. Barrio, for your presentation.
You're welcome. Thank you.